Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. I'm your host, Patrick Hotzel from intensivecarehotline.com and intensivecareathome.com. I'll do these YouTube lives every week, once a week, emergency questions and answers for families in intensive care and intensive care at home. And I want to welcome you to another live stream. We also want to welcome the viewers that watch this on replay. This is your opportunity to ask questions to me live. You either type them into the chat pad or you connect with me live here on StreamYard. And I'll post the link in the chat pad how you can talk to me live directly here. Here it is. And if you like the work that I'm doing here, subscribe to my YouTube channel. For regular updates for families in intensive care and intensive care at home, click the like button, click the notification bell, and comment or connect with me directly here so that I can create the content that you want to know about. You know, the best news about my YouTube channel is I create the content that you want, you know, because I answer your questions, I pay attention to what emails you're sending or what phone calls I'm having and so forth. So I usually go for about an hour. So, you know, we wrap this up in about an hour. Also, want to welcome the viewers in Australia, in the UK, in Ireland, in Canada, in America, of course, in the USA. Want to welcome all of you, but of course, also our viewers in India or anywhere around the world. What makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? Like I said, my name is Patrick Hotzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager in intensive care for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently, very confidently say that we have saved many lives for our clients in intensive care, and you can verify that on our testimonial section at intensivecarehotline.com, where you can see what our clients are saying, and you can also verify it on our intensivecarehotline.com podcast section, where we have done client interviews. Because our advice for families in intensive care is quite literally life-changing. It is absolutely life-changing. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are currently sending our critical care nurses into the home 24 hours a day for predominantly ventilation and tracheostomy, but also for our clients on non-invasive ventilation, such as BiPAP, CPAP, for tracheostomy care without ventilation, home TPN, home IV magnesium infusion, home IV antibiotics, home IV fluids, PICC line, central line, Hickman's line, port management at home, cough assist management at home, palliative care and ventilation weaning at home as well. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. As part of that, we're also providing level 2 and level 3 NDIS support coordination. Right, without further ado, let's go into today's questions. If you have any questions, please type them into the chat pad or connect with me live here on the StreamYard link. I do want to start with a question that's coming from Peter, who says, "Hi Patrick, I would like to ask if you know if there's any form of precedence for being interrogated whilst unconscious in ICU, whilst in an induced coma in Australia and unable to defend oneself under the effects of medicine delivered via central line with fentanyl, rocuronium, ketamine medical infusion." As I'm aware that under the Human Rights Act or the Mental Health Act, these actions without consent are generally considered highly illegal in most instances, especially when asked non-relevant medical information questions, which could be then used against your critically ill loved one in their future healthcare treatments. As I'm aware of the practice within the medical establishment, due to being poorly medicated and able to remember the experience, and now thus effectively able to highlight the facts surrounding the concerning process that can occur in ICU departments. Your integrity to honestly answering these questions is a demonstration of your years of experience and to the great advantages of anyone using your invaluable services of intensive care at home and intensive care hotline, for which I can highly recommend as inspirational and truly inspiring in helping to benefit the recovery of critically ill loved ones, leading to a better quality of life for them and their families. From Peter. Well, Peter, thank you for raising this very serious and complex issue to address your questions in more detail. So I'm not aware of any lawful precedent or ethical justification in Australia or in most democratic countries for interrogating a patient who's unconscious, sedated, and or under an induced coma in the ICU, especially under medications such as fentanyl, rocuronium, and ketamine, which are known to induce amnesia, paralysis, and loss of consciousness. Any attempt to question such a patient, particularly for non-medical purposes or with the intent of extracting information to be used against them or their care decisions, could constitute a serious breach of medical ethics, patient rights, and potentially criminal law even. Let's look at the legal and ethical context. There's the Human Rights Act, because these laws, generally speaking, uphold the right to freedom from inhumane or degrading treatment and privacy, and require informed consent for any interaction beyond essential life-saving measures. Next, in Australia and in other countries such as the US or in the UK, there's the Charter of Healthcare Rights. In Australia, it is endorsed by the Australian Commission on Safety and Quality in Healthcare, and it clearly supports respect for patients and families, the right to participate in decisions about their care, the right to privacy and confidentiality. There's also the Mental Health Acts, vary slightly by state, but even when a person is deemed to lack capacity due to sedation or coma, they're still protected under guardianship and substitute decision-making frameworks. Any questioning not related to immediate care is highly inappropriate and likely unlawful. Next, there's medical and ethical violations. Sedated or comatose patients cannot give consent, nor can they be expected to process or respond to questions. Using information, quote unquote, gathered under these conditions to inform future care or legal decisions without transparency and consent would likely violate informed consent doctrines and could be challenged legally. Next, documentation and reporting. If you or a loved one has experienced this, document everything you remember: dates, names, statements, sensations. Always, and I repeat, always request medical records, especially progress notes and any audio, video surveillance if applicable. But can't stress enough, doesn't matter where you are, Australia, US, UK, you always need to request medical records. Always, always, always. I can't believe how many inquiries we have every week where people have not sought access to medical records, and that's a big no-no. You need to access to medical records as one of your first steps. You need to seek advocacy as one of your first steps. You cannot be flying blind when you have a loved one critically ill in intensive care. Next, file a complaint with the hospital patient liaison or patient liaison, your state's health complaints commissioner. You could file a complaint with the hospital ethics committee, but I have my reservations there. But I want to mention it regardless, because ethics committees are usually employees of a hospital, and they are not objective. They are bound by the rules of their hospitals, of their employees. So we'll be much better off with, engaging us here at intensivecarehotline.com, because we are impartial, and if anything, we have the best interest of our clients at heart, whereas a hospital has the best interest of a hospital at heart, which does not often correlate with the best interest of a patient or a family. So again, lodge complaints with the State's Health Complaints Commissioner or Department of Health. Also, you could lodge a complaint with the Australian Health Practitioner Regulation Agency, APRA, if any individual clinicians are or were involved. Your ability to remember and report these events despite sedation should not be dismissed and may reflect gaps in protocol, possible overuse, misuse of paralytics and sedation, or neglect of your rights. So I hope that helps you understand, Peter. I find it hard to believe that this is what's happened, but obviously that is what you're sharing with me, and I know you wanted me to share this on my video regardless. What is something that comes to light here over and over again, and I've seen it, in my own clinical practice, of course, is that ICU teams can be overtly negative in front of a patient and a family, and the patient can't talk, and ICU teams are often very nonchalant, I should say, or oblivious to the fact that they're talking in front of a patient saying, oh, if this person will survive, they won't have any quality of life. It's not in the best interest of them to survive, because only we know what's best, and that's highly inappropriate to make those comments in front of a patient or a family, especially when the patient can't talk, or potentially has a brain injury but is unable to verbalize. This is not a conversation you should have with a patient that's in a coma. It is a conversation that you can have with a patient that is awake and can speak for themselves. But even then, I'm finding that a lot of ICU teams are very cowardice, and they just say what they want to say without actually discussing it with a patient or a family. Or if they do discuss it with the family, because the patient can't talk, it's, sort of, they're making the quote unquote rules, that this person can live, this person should die. Don't let somebody else's opinion about something become your reality, right? You can live in your own reality. That's a choice you can make. It's actually a choice you need to make when you have a loved one critically ill in intensive care. You need to create your own reality, and you need to create circumstances where your critically ill loved one is having the best environment so that they get best care and treatment always. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is exactly what most families are dealing with. You don't know what you don't know. And that is something you need to find out as quickly as possible. So many families come to us when they're too far down the tracks, or they come to us when it's way too late. They come to us when their loved one has passed away. And then they do online research when it's too late, and they say, oh, we didn't know there was advocacy. We didn't know you could have helped us save our loved one's life. Well, the other thing that you need to do is, when you have a loved one critically ill in intensive care, you need to take full responsibility for outcomes. I know it's not what you want to hear, but you do need to take full responsibility for outcomes and see how the world changes around you, right? And I mean that in any positive sense. If you just go with the flow and go with what intensive care teams are throwing at you, what they want, you'll be fighting an uphill battle, big time, right? So you can never, ever accept a reality that doesn't work for you. Intensive care teams are very good at creating narratives around doom and gloom in particular. You can create your own narrative, and that narrative can't be about doom and gloom. can be about positivity, it can be about healing, right? It can be about the steps that need to be taken to get your loved one from A to B, right? I could share so many inspirational stories here, and you can watch it on our blog at intensivecarehotline.com, but also at Intensive Care at Home, where families in intensive care were told that their loved ones, A, won't survive, B, if they do survive, they won't have any quality of life. Therefore, it is quote unquote in their best interest to die. What a whole lot of rubbish. And it's up to patients, it's up to families what they want. It's not up to ICU teams to play God and walk around and say who should live and who should die. ICU team's job is to save lives. Plenty of time to talk about end of life in ICU. Plenty of time. It's no rush, So let's move on to the next question from Susan that I had in the last couple of weeks. But, if you have any questions in the meantime, while you're watching live, type your questions into the chat pad or connect with me live here on the StreamYard link that I posted in the chat pad. In the meantime, question from Susan. How can you turn your intensivecarehotline.com quick tips for families in intensive care into changing laws? I spoke with you a few months ago about my brother, who they were trying to discharge from ICU in a coma to LTAC or anywhere we would allow them to. Fortunately, I was able to get hospital administrators involved and he was moved to another unit in the hospital, which is the much better option compared to LTAC. However, in retrospect, he should have stayed in ICU until he woke from the induced coma he was put in. Susan, I agree with all of what you're saying here. Obviously this is, and Susan was one of our members. We also, by the way, have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, by the way, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. If you are a member, you also get a 20% discount to any of the phone consulting and advocacy options that I offer. Back to Susan's email. So, number one, never ever let your loved one go from ICU to LTAC. What's LTAC? LTAC stands for Long-Term Acute Care Hospital. It is very unique to the US. So we're talking about what's happening in the US here with LTACs. Many patients in the US go from ICU to LTAC once they have a tracheostomy and a PEG tube. It is highly inappropriate. It's dangerous. It's putting patients' and families' lives at risk, puts family unity at risk because, often when patients go from ICU to LTAC, it upsets the status quo. Often patients are being sent hours away from the hospital that's often close to home for families, right? So it is highly inappropriate going from ICU to LTAC. But it's not only that it's inappropriate, it's very unsafe. I encourage you, if you're in the US, to look up online reviews for LTAC. I strongly encourage you to look up online reviews for LTAC. And I also strongly encourage you to look up how those online reviews compare to what LTACs are advertising on their website. So, for example, LTACs advertise on their websites that they are specialized in ventilation and tracheostomy weaning, right? Compare that with the reviews that you see online from families who have loved ones in LTAC or had loved ones in LTAC. I've made a video maybe a year ago or 18 months ago, I can't quite remember, 10 reasons why LTACs in the US are a scam. And I stand by every word that I'm saying there, right? They are a scam. They're not even the beta version of a nursing home, and ICUs yet are trying to discharge patients, critically ill patients, I should say, to an LTAC, which is not even the beta version of a nursing home. If you let that happen for your loved one, you are also negligent. We have helped so many families to keep their loved ones in ICU instead of going to LTAC. But you can't leave it until the last minute. If you're leaving it until the last minute, you're also negligent. So let's come back to Susan's email. So how can we turn the quick tips here in laws? Well, first off, Susan, thank you for the update on your brother. I'm really glad that you were able to advocate for him and get him transferred to a safer part of the hospital. You're absolutely right. Patients in medically induced comas often require the highest level of monitoring in intensive care, especially if they're ventilated with a tracheostomy, which I know was the case with your brother. And discharging them to an LTAC, long-term acute care facility, too early can be dangerous and inappropriate. And really, I argue that an LTAC has no time and place in the healthcare system. LTACs have been designed to save money and deliver inappropriate care. They have been designed to save money and free up ICU beds. But that's not always what happens, because what often happens is that patients go from ICU to LTAC, and then they bounce back to ICU within no time, within 24, less than 48 hours, right? And then they occupy another ICU bed. And then there's no guarantee that when going from LTAC back to ICU, that the ICU where your loved one came from, this was discharged from, still has a bed available. So then they go to another ICU. So picture this, your loved one with a critical illness goes from ICU to LTAC back to another ICU in 3 different places in no time. That is madness, it's negligence, and it needs to stop. Now, whilst I want to look at changing laws in a minute, I haven't finished with my answer to Susan. However, the first thing that you need to do, despite us trying to change laws, is you need to start advocating from day one. If you're not doing that, you are failing your loved one. Okay, so how can we change the quick tips into laws? Number 1, document the problem clearly. Write down what happened, what almost happened, the risk of early discharge in a coma, what you did to intervene, what should have happened, the standard of care you believe should be in place, and of course, the outcome. This becomes the foundation for a personal case study or a public story to raise awareness. Number 2, identify the policy or legal gap. Ask what allowed this to happen. What allowed your loved one going from ICU to LTAC? What was it? A lack of regulation, a loophole in the hospital discharge procedures, inadequate standards for ICU transfers? For example, there's currently no law requiring ICU patients to remain in that unit while in a medically induced coma if insurance stops covering it. But most of the time, it's not even so much a gap of policy or legalities. Most of the time, it's a gap of your knowledge. It's a gap of you not being able to advocate in the right way. You're not understanding intensive care inside out, which is what we know intensive care inside out here at intensivecarehotline.com, and we can bridge the gaps for you very quickly. Just because an ICU says your loved one needs to go to LTAC, you need to question. If you're not questioning, you're your own worst enemy. Like I said, do not let other people's thinking about something become your reality. That is your choice, and your choice only. Next, connect with advocacy groups such as intensivecarehotline.com. We can only advocate for you. The more stories you bring to us, the more we can help you, the more we can advocate on a bigger level. And you don't have to do this alone. There's other many national and state organizations working on improving patient safety, hospital accountability, and long-term care standards. Some examples in the US are, of course, here intensivecarehotline.com, National Patient Advocate Foundation, Center for Medicare Advocacy, Public Citizens Health Research Group. They can help with packaging your story, developing policy proposals, get legal insight, mobilize others. And you can also be a guest on our intensivecarehotline.com podcast. I argue we have now a wider reach than many of those organizations that I just pointed out. Next, engage legislators. Start with your state representative or senator. Bring them your documented story and a simple task. Introduce or support a bill requiring medically induced coma patients to remain in ICU or step down ICU until they regain consciousness, unless there's any other medical justification. Legislators often respond to real stories with a clear injustice. Now, the interesting part is, ICUs often see the trigger point for patients going from ICU to LTAC just when the tracheostomy is done and when the PEC tube has been done. That is often the trigger point. And I can tell you that is just wrong. And that shouldn't be a trigger point. There should never be a trigger point for LTACs. I really question the legitimacy of an LTAC, right? If they're not getting results, right? Next, use public pressure in the media. Write an op-ed or personal essay for a local paper or a national platform. Share your story on social media with a call to action. Consider doing interviews, which I can offer you here at intensivecarehotline.com, especially if others have faced similar treatment. Next, propose a concrete rule or policy. Even if you can't change a state law right away, you can push for hospital policy changes at a local level, state health department guidelines, Medicare, Medicaid, administrative rule updates. And never be silent. I can't tell you how many families reach out to us and say, oh, I don't want to speak up, I'm intimidated. Well, skip that. Skip that. Families that get results for their loved ones in ICU are not intimidated, they're not scared. Right? So what does it look like in more practical terms? So let's begin with a case summary on policy recommendation you can use in letters to lawmakers, advocacy groups, or media outlets. Here's the first draft based on what you've shared. Subject: protecting ICU patients in medically induced coma, a call for policy reform. Summary of your brother's case. A few months ago, my brother was placed in a medically induced coma in the ICU due to a life-threatening condition. While still unresponsive and critically ill, the ICU team attempted to discharge him to a long-term acute care facility or anywhere we would allow them to send him. This was not based on medical improvement, but seemingly on administrative pressure to vacate the ICU bed. At the time, I intervened by escalating the issue to hospital administrators. Fortunately, my brother was transferred to another unit within the hospital. However, I now realize he should have remained in the ICU until he regained consciousness. Transferring a patient in a medically induced coma out of intensive care without clear medical justification puts their life and recovery at serious risks. Why this matters: there are currently no universal standards or legal protections preventing hospitals from prematurely discharging patients in medically induced comas to lower levels of care, particularly when insurance pressures or bed availability become factors. Families often do not have the medical knowledge or authority to challenge these decisions in time. Policy recommendations: I urge state and federal health authorities, legislators, and hospital regulatory bodies to consider the following. Require medical justification and documentation before ICU discharge of any patient in a medically induced coma. Mandate an appeal or review process for families objecting to ICU discharge of unresponsive patients. Ban transfers to LTAC or skilled nursing facilities for patients in active comas without neurological reassessment and attending physician sign-off. Create public reporting mechanisms for families to report unsafe or premature transfers. Call to action: please consider sponsoring or supporting legislation that protects patients like my brother. No family should have to fight to keep their loved one in intensive care when they are still unconscious and unable to advocate for themselves. This is a matter of patient safety and dignity, and this is a matter of urgency. So there are ways forward, but you need to take the right steps, and you need to never give up, and you need to fight from day one, right? If you are not advocating for your loved one, no one will. That is the bottom line. No one will if you don't. Okay, now apologize that I just had to take myself off camera. I'll be right back on camera in 1 minute. In the meantime, I want to shift gears a little bit and let's come to some intensive care at home questions. So we've covered some intensive care hotline questions. Now I want to shift gears and talk more about intensive care at home questions that have come in. One question that has come in is that ICU and ventilation tracheostomy care is very difficult, if not impossible, with a spinal cord injury. Moving too much and not able to wean off the ventilator due to the routine care given in ICU makes it hard for my loved one in ICU. Is going home with intensive care at home the best option? Well, and this is an email from Clara. Well, Clara, your concern is extremely valid. With a spinal cord injury, especially if it's high level, like C1, C2, C3, your loved one may have little or no control over the muscles needed to breathe independently. They can make weaning off a ventilator extremely difficult or even impossible. Add to that the constant stimulation from ICU routines, turning, suctioning, and noisy surroundings, and it can be exhausting and even distressing for someone trying to recover. In that context, yes, going home with an experienced service like intensive care at home is the significantly better option for most families, and here is why. Benefits for intensive care at home are clearly more comfort and stability. A calm, familiar environment reduces stimulation and allows for better rest and healing. Next, individualized attention. You're not sharing staff with dozens of other patients. Care is very focused one-on-one at home. Reduced ICU complications, lower risk of hospital-acquired infections and ICU delirium. Family involvement. You're closely involved in care decisions and daily interactions. Same level of ventilation and intensive care support, because intensive care at home services provides intensive care level care, including tracheostomy and ventilator management only with intensive care trained nurses. Other considerations: you need to ensure that the home is equipped and safe, power backup, suction equipment, emergency access, backup ventilator, backup suction machine, monitors, hospital beds, nebulizer, hoists, lifting machines, hospital beds, air mattress, wheelchair. Potentially your home needs modification, and the quality of the home care team is critical. Make sure, you choose the right provider like intensive care at home, where you exclusively get ICU level trained nurses. We are employing hundreds of years of intensive care nursing experience combined. No other service provider in the community can offer that. So, what questions should you be asking? When it comes to your loved one's challenges with spinal cord injury, tracheostomy, and ventilator dependency, transitioning to home care with a specialist service like intensive care at home. It's a very good option. The service offers 24/7, our service offers 24/7 intensive care trained level nursing care in the home, in the comfort of your own home, I should say, with the goal to improve quality of life and potentially facilitate weaning from mechanical ventilation in a less stressful environment. That's assuming your loved one is able to be weaned off the ventilator with a spinal injury. I don't know how high the spinal injury is, but the key benefits for intensive care at home from our perspective are: it's specialized in home care nursing, because it provides critical care nurses experience in managing ventilation and tracheostomy patients, ensuring high quality care outside the hospital setting, but still at an intensive care level. Next, comprehensive services beyond ventilation and tracheostomy care. Services include management of central lines, TPN, and palliative care tailored to individual client needs. And this is the whole secret of intensive care at home, tailoring it to your needs, not to the hospital needs, and having a say in you creating your own care plan or your own care plans. you know, that is really important. Next, accredited provider. Recognised as the only service in Australia with third-party accreditation for intensive care nursing in the home, reflecting adherence for best practice guidelines. And when we are talking about best practice guidelines, we are talking about the mechanical home ventilation guidelines in particular, right? So you should look at intensive care at home website, and you should go to the section mechanical home ventilation guidelines, where it's clearly documented and it's evidence-based that exclusively critical care nurses with a minimum of 2 years critical care nursing experience can safely provide care to ventilated and tracheostomy clients in the home. And that also includes if a client is at home on a tracheostomy without ventilation. If a client is at home on non-invasive ventilation without tracheostomy, it still requires 24-hour intensive care nurses. Many of those patients also require cough assist devices, which is also the skill of a physiotherapist that has worked in intensive care, or the skill of a critical care nurse. Funding support, obviously approved provider under NDIS, TAC, and so forth, which may assist in covering the costs associated with home intensive care. Well, it's not only assisting, it is paying actually for the service. What are considerations before transitioning into the home? Home preparation, ensuring the home environment is equipped with necessary medical equipment and safety measures, including backup power for ventilators. Care coordination, that's also part of what we do, developing comprehensive care plans in collaboration with healthcare providers to ensure seamless transition and ongoing support in the community. Training and support for our staff, of course. We cannot train support workers or our family members, because we can support families, of course, to that with that transition. But like I said, families in intensive care wouldn't deliver care, and it's the same in a home care environment. Sometimes families can help, of course, but they cannot deliver the intensive care nursing tasks that are required for a patient. So what questions should you be asking us, for example? You can ask us about experience and qualifications. Of course, what's the level of experience and training of the nursing staff we employ in managing ventilated and tracheostomy patients? Next, care continuity. How is continuity of care ensured? What is the nurse-to-patient ratio? Well, the nurse-to-patient ratio is always 1-to-1. Always 1-to-1. Emergency protocols. What emergency protocols are in place, and how quickly can additional support be provided if needed? For example, we have our own intensive care specialists. We have, senior nurses on call. There's a good level of support as part of our infrastructure. Coordination with other healthcare providers. How does the service coordinate with hospitals and specialists to manage ongoing care and potential complications? Again, that's where also our senior management team is coming in, but also for some of our clients, we have clinical care coordinators that coordinate the individual care for some of our clients 1-to-1. Again, what's the costs involved and what funding options are available through programs like NDIS, TAC, iCare, etc., DVA. So, it's fairly simple. So what does a nursing care plan look like for a C1 spinal injury client transitioning home from ICU, right? So comprehensive nursing care plan tailored for a C1 spinal cord injury client transitioning from ICU to home with 24 hours CCRN, critical care registered nurses support. This plan includes priority assessments, interventions, goals, and equipment needs to maintain safety, comfort, and quality of life. Now, let's look at C1 spinal injury, cord injury, home intensive care transition from ICU. Diagnosis: complete C1 spinal cord injury. Status: ventilator dependent via tracheostomy, PEG-fed, quadriplegic, requires 24/7 monitoring and support. Goals: maintain airway, prevent complications, ensure comfort, dignity, supportive family, and of course, maintain and maximize quality of life, including community access. And the reason I want to stress community access here is that all of our clients have community access or have the ability to have community access. You know, if they don't, then it's often their choice not to access the community. But I do want to stress comparing community access to living in an ICU. You know, being stuck in a bed space in ICU, often without natural daylight for weeks and months on end. Compare that to going home and having community access every day. Big difference. So what does airway and ventilator management look like at home? For a C1 client, nursing diagnosis, ineffective airway clearance, complete loss of motor function, tracheostomy and ventilator dependence, maintain airway patency, prevent ventilator-associated complications, ensure ventilator functioning 24/7. That includes, you know, having battery backup of the ventilator. That includes having power backup of the ventilator. That may include, in some locations, having a generator on site, right? Interventions, monitor ventilator settings, alarms, and respiratory parameters hourly, which is what we're doing at home, especially overnight. Maybe not so much during the day when we're out in the community with our clients, but, you know, generally speaking, we hour all of that. We monitor all of that hourly. Suctioning tracheostomy as needed using sterile technique. Provide humidifications via ventilator circuit or HME filter. You know, HME filter is really only when a client is not at the bedside. Provide nebulizer treatment when needed. You know, most clients on a ventilator with a tracheostomy should have some form of nebulization multiple times a day to keep the airway clear and airway patent. Provide humidification via ventilator circuit or HME filter. Change tracheostomy ties, tracheostomy dressings as per protocol. Keep emergency tracheostomy kits, ampu bag, suction available at the bedside, but also at all times, even during community access. You know, we're taking emergency bags with us when we're entering the community with our clients. Sometimes we need to perform routine and PRN arterial blood gases, monitor for signs of CO2 retention or hypoxia. Next, nutrition and hydration. Nursing diagnosis, imbalanced nutrition less than body requirements, with an inability to swallow. Goals: maintain stable weight and hydration, prevent aspiration and infections. What are interventions? Administer a PEG tube and then administer PEG feedings as prescribed, continuous or bolus. And before you tell me that you've heard me saying multiple times on this channel that I, generally speaking, do not recommend a PEG tube, that is still the case. However, for a C1 ventilated client, there is no other way but to have a PEG tube. And I've always said that PEG tubes have their time and their place. But for most ICU patients, a PEG tube is not needed. An nasogastric tube will do, but not for a C1 patient. That is one of those rare exceptions where a PEG tube is actually needed. So once a PEG tube is inserted, you know, flush PEG tubes before and after giving feeds, medications, etc. Keep monitoring for signs of intolerance, nausea, residuals, bloating, diarrhea. You know, you might have to vent the PEG tube every so often for bloating to let off air. Monitor labs, electrolytes, albumin, glucose, and also, like I said, vent the PEG with a bladder syringe every so often if there's bloating. Also, if there's issues with digestion, if there's high residuals, you know, maybe a patient needs to be started on some metoclopramide or any other medications that will help with digestion and absorption. Next, skin integrity and pressure injury prevention. Risk for impaired skin integrity, return immobility and decreased sensation. Goals: prevent pressure injuries, maintain skin integrity and intact skin. What are the interventions needed? Patient needs to be turned every 2 hours using appropriate technique and lifting devices. Use pressure relieving mattress and cushions. Inspect skin daily, especially over bony prominences. Apply barrier creams and keep skin dry and clean. Next, infection prevention. Nursing diagnosis, risk for infection return. Risk for infection with invasive devices such as tracheostomy, PEG tube. Immunocompromise. Goals: prevent hospital-acquired infections, early identification of infection signs, perform tracheostomy care per sterile technique, maintain PEG and urinary catheter care with strict hygiene, monitor for fever, changes in secretions or white cell count trends. Adhere to hand hygiene and PPE protocols for all caregivers. Next, bowel and bladder management. Nursing diagnosis, functional incontinence, neurogenic bladder and bowel. Goals: prevent urinary retention, infection and constipation, of course. What are the interventions? Perform intermittent catheterization or manage indwelling catheter or an SPC. SPC stands for suprapubic catheter. Administer bowel regimen, stool softeners, suppositories. Make sure there's enough hydration. Monitor in and output, fluid balance, signs of UTI or bowel obstruction, God forbid. Next, what does psychosocial and family support look like? Nursing diagnosis, risk for situational low self-esteem and caregiver strain. Goals: promote emotional well-being for patient and family, empower family to participate in care. Interventions: involve family in routine care if they want to, provide teaching and emotional support, facilitate communication via assistive technology, eye gaze or yes or no boards or letter boards. Coordinate regular counselling or pastoral visits if required and requested. Also, spiritual support might help. Arrange respite care and community resources, home physical therapy, OT, case management. Next, emergency preparedness. Goals: ensure rapid response in emergencies, prevent avoidable transfers, maintain emergency power backup for ventilation and suction equipment, train all the staff in CPR, ventilator disconnection protocols and tracheostomy emergencies. Of course, once again, this is all part of having critical care nurses employed exclusively, which is what we do here at Intensive Care at Home. And establish clear protocols for when to escalate to emergency services or hospital transfers. We have an internal KPI of having no hospital readmissions or no non-elective hospital readmissions. So, I always tell our staff and other senior managers do the same. What do we need to do today to make sure our clients are home tomorrow? Very important question to ask. Now, next, required equipment at home for a C1 ventilated tracheostomy client, ventilator with backup ventilator, suction machine with backup suction machine, and the necessary equipment that goes along with it: suction canisters, suction liners, Janka suckers, suction catheters for the tracheostomy. Then oxygen cylinders and ideally an oxygen concentrator, emergency tracheostomy kits, ampu bags, PEEP valve. If a client, for example, has a size 8 tracheostomy, there should be a size 8 tracheostomy as a backup, and there should also be a size 7 tracheostomy backup in case you can't get the size 8 back in. Next, PEG tube supplies, backup pump, but also backup PEG tube, power backup, like I said, generator or UPS, pressure relieving mattress, ideally an air mattress, patient lifting system, i.e. hoist or ceiling hoist lifting machine, wheelchair, communication board, communication board, speaking device, eye gaze computer, pulse oximeter, thermometer, monitor, hospital bed with side rails to prevent the patient from falling out of bed. So I hope that helps clarify what it looks like for patients with a C1 spinal injury at home. And like I said, what's also important to know is that all of our clients, C1, C2, M&D, they all have community access without exception. So a lot more is possible at home than you think there is with the right level of support, of course. That is really important, that you actually get the right level of support at home. So, let's also look at the questions. And a question that's come in during the week. What are the criteria for an uncuffed tracheostomy to be removed? But before we look at that, we probably need to establish what's the difference between a cuffed and an uncuffed tracheostomy. So the decision to use a cuffed versus uncuffed tracheostomy depends on several clinical factors. The breakdown of when each type is typically used is cuffed versus cuffed tracheostomy tube. The indication is ventilator support, prevents air leak and ensures adequate ventilation. Aspiration risk, the cuff helps protect the airway from secretions and gastric content. Poor upper airway protection if the patient has reduced consciousness or impaired swallowing reflex. Lung hygiene when frequent suctioning is needed, especially in patients with poor or non-existent cough. Uncuffed tracheostomy tube, indication spontaneously breathing patients not on mechanical ventilation. Low aspiration risk when airway protective reflexes are intact. Or for pediatric patients, commonly used in children to avoid tracheal damage from cough pressure. Speech and swallowing assessment allows more natural airflow and voice production during weaning. What are other considerations during weaning from ventilator? Patients often transition from cuffed to uncuffed or cuff deflated tubes as they improve. Tracheal damage risk, long-term cuff tubes should be monitored for pressure injuries. Right? So that's number one. Then, when can an uncuffed, what are the criteria for an uncuffed tracheostomy to be removed? The removal of an uncuffed tracheostomy tube, often called decannulation, depends on several clinical criteria to ensure the patient can breathe effectively without airway compromise. Here are the typical criteria: stable respiratory status, no need for mechanical ventilation or high oxygen support, adequate oxygen saturation on room air or minimal supplemental oxygen, effective airway protection, strong cough and ability to clear secretions, no signs of aspiration or frequent choking. Swallow evaluation, if needed, shows safe swallowing. Patent upper airway. The upper airway, nose, mouth, throat, larynx is open and unobstructed. Successful capping trials. The trach tube is capped, blocked for increasing periods of times to see if the patient can breathe through the mouth and nose. Laryngoscopy or bronchoscopy may be used to assess airway patency. Adequate mental status. Awake, alert, and able to follow commands, can express discomfort or distress if breathing becomes difficult. Low tracheal secretions. Secretions are minimal and manageable without frequent suctioning, ideally fewer than 2 times per day. And that is the main difference here. For an uncuffed tracheostomy to be placed in the first place, patients need to be able to swallow, which we've clearly identified. And then the major indicator to have an uncuffed tracheostomy removed is really that the patient no longer needs suctioning and has a good strong cough and is able to protect their own airway and is able to cough up any secretions. Next, successful capping plugging trials. The patient tolerates a capped tracheostomy tube for several hours or even 24 hours. No signs of respiratory distress, desaturation, or increased work of breathing. And of course, doctor's assessment, nursing assessment, physio assessment, and team agreement. The multidisciplinary team, ENT, respiratory physician, ICU nurse, speech pathology agrees that the patient is ready to have the uncuffed tracheostomy removed. So there is even a decannulation checklist, number 1, and that is for an uncuffed tracheostomy tube. Breathing spontaneously, no mechanical ventilation, stable oxygenation saturation on room air, or less than 2 liters, minimal supplemental oxygen, no signs of respiratory distress, nasal flaring, accessory muscle use, airway clearance, strong effective cough, able to clear oral tracheal secretions independently, requires suctioning fewer than 2 times a day, upper airway patency, upper airway confirmed patent via endoscopy if needed, past speaking valve and/or capping trials, capped for 4 to 24 hours without distress, no signs of upper airway obstruction, stridor, voice change, swallowing and aspiration risk, swallowing function evaluated by speech-language pathologist, no significant aspiration risk, able to swallow saliva and possibly eat orally, depending on the case. Mental and neurological status, awake and alert, able to follow commands and express needs, discomfort, no recent seizures or altered mental status that might affect airway protection. Other medical considerations, no recent acute infections, respiratory or systemic, hemodynamically stable, blood pressure and heart rate within normal limits. Then 15-minute capping trial should have been tolerated, an hour capping trial should have been tolerated 4 hours. There might be mild secretions that are manageable, 8 to 12 hours, breathing well and alert, 24 hours past, consider decannulation. Final step, medical nursing, ENT, speech therapy team signs off, multidisciplinary team reviewed and agreed patient is ready, emergency equipment on hand during decannulation, monitoring plan in place for first 24 to 48 hours of post-decannulation. So, I hope that helps and I hope that answers your questions. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care home. Click the like button, click the notification bell, share the video with anyone that you think will benefit from this, and click the notification bell. If you want intensive care home for your family member, like I said, we're currently operating all around Australia, and you can find more information at intensivecarehome.com. If you're in the US or in the UK and you need intensive care home, reach out to us. We can help you with hiring nurses privately, and we can help you with setting it up. If you need NDI support coordination, we're providing NDI specialist support coordination, especially when it comes to transition from ICU to home. And if you need consulting for your consulting and advocacy, I should say, for a loved one in intensive care, go to intensivecarehotline.com. And like I said, we have helped hundreds and hundreds of members over the clients. We have saved so many lives in intensive care for our clients through our consulting and advocacy, right? And because we improve our clients' lives instantly, making sure they make informed decisions, have peace of mind, control, power and influence, making sure their loved ones get best care and treatment always. And that's why I do also one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. No longer Skype, by the way. Did I say Skype? Skype is no longer a platform for communication. And I handhold you through this once in a lifetime situation when you have a loved one critically ill in intensive care that you cannot afford to get wrong. I also talk to doctors and nurses directly with you or on your behalf, and I ask all the questions that you haven't even considered asking but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also review medical record reviews medical records after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. All of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. and go and check out intensivecarehome.com as well and contact us there. That's it for today. I will see you again next week, same time. I wish you all a good week. Look after yourselves and take care for now.